Welcome to the Long COVID and Post-Infectious Syndrome Echo, a collaborative effort between the University of Utah and Bateman Horne Center. I'm Clayton Powers, Doctor of Physical Therapy at the University of Utah and also Education Liaison for Bateman Horne Center. I'm joined by Sarah Day, Project Echo Lead at U of U. Today's session is being recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. After the session, Sarah will email CME instructions, and we won't be emailing the slide deck afterwards because some of this is unpublished data that we're not able to share at this time. Please note that CME credit must be claimed by midnight tonight, and it can take up to 24 hours to appear on your CME profile. We invite you to introduce yourself in the chat. Tell us where you're coming from, your institution. And for today's session, you'll not be able to unmute yourself to ask a question, but feel free to use the chat to ask questions or make comments. We also want to remind everyone that this is a clinician-only forum, so we try to stay professionally focused. Today, we're privileged to have Beth Pollack and Sangmita Singh joining us today to share their research. Beth Pollack is a research scientist at MIT in the Department of Biological Engineering in the TAL Research Group. Beth's research focuses on shared but understudied pathologies across infection-associated chronic illnesses that significantly impact patients, and she's led the lab's expansion into ME/CFS, connective tissue, and environmental sensitivities research. Beth has expertise in clinical study and clinical trial design. She has co-developed and is currently collaborating on 7 clinical studies across 6 institutions, most involving multi-illness IACIA cohorts. She has held multiple leadership roles in the field. She serves on 2 NIH Recover working groups focused on long COVID therapeutics and clinical trial design, and has been co-designing an NIH clinical trial evaluating GLP-1s in long COVID. She was chair of the NIH ME/CFS Research Roadmap subgroup on less studied pathologies, co-authoring the NIH's National Research Roadmap to advance ME/CFS research toward clinical trials. And then she was also previously a senior researcher at Harvard, and in 2024 was named a United States leader by the Obama Foundation. Beth cares deeply about increasing awareness and understanding of these illnesses and has been interviewed by the New York Times, The Atlantic, The Guardian, NPR, and other publications. We also have Sangmita Singh. She's a technical associate at the TAL Research Group supporting the Maestro clinical study. Sangmita graduated in May 2024 from Johns Hopkins University, earning a BS in biomedical engineering. She recently earned a Master of Public Health from Boston University and will be beginning medical school this summer. At the TAL Research Group, Sangmita supports the Maestro clinical study, engaging directly with participants, running neurocognitive testing, biobanking, performing laboratory experiments, and analyzing data. She is honored to contribute to such meaningful work alongside a driven and a dedicated team. Thank you, Beth and Sangmita, for joining today and being willing to share with us today. Go ahead and share your slides. The time is yours.
Hi, everyone, and welcome. Thank you so much for inviting us today to talk. So today we'll be giving 2 talks covering both existing and emerging research on long COVID and infection-associated chronic illnesses, or IACI, including ME/CFS and chronic Lyme disease. First, I'll be giving a talk on reproductive health in IACI, and then Sangmita will be sharing about our lab's research and findings on Nailfold capillaroscopy, which visualizes capillaries and may provide new insights into microvasculature and blood flow, and potentially maybe a new tool for studying this, which is very relevant to these illnesses. So first, I'll be talking about reproductive health conditions in long COVID and relating infection-associated chronic illnesses. And this first talk is a combination of reviewing existing research, including a review that we previously wrote, and then sharing about new and emerging research since this review was published, which includes research that I'm collaborating on. Nothing to disclose. So I'm going to start with the review and what we know, and then segue into newer areas of research, and try to go quickly because I'm also very excited about Mita's talk today. So I worked with my colleagues at the Patient-Led Research Collaborative, or PLRC, to write the first review of reproductive health impacts of long COVID. We contextualized these findings by drawing on research evidence of female reproductive health in illnesses that are often comorbid with long COVID, such as ME/CFS, POTS, and Ehlers-Danlos syndrome, or EDS. To summarize our findings, these illnesses individually have increased rates of infertility, endometriosis, ovarian cysts, uterine bleeding, lacking menses, irregular and inconsistent menstruation, intermenstrual bleeding, menstrual cramps, vulvodynia, painful intercourse, early menopause, pelvic congestion syndrome, gynecological surgeries, and adverse pregnancy complications, such as preeclampsia, maternal mortality, and premature birth. Premenopausal women have a higher risk for long COVID, as many of us know, and may also have a higher risk for ME/CFS, particularly ages 10 to 19, 30 to 39, suggesting that sex hormones and sex differences in immune responses to infection may play key roles in both these illnesses and their onsets. So first, I'm going to talk about the menstrual cycle. Studies show that between a third and 62% of premenopausal long COVID patients commonly experience an exacerbation of their long COVID symptoms in the days before menses, as well as a worsening of premenstrual symptoms. So similar to ME/CFS, menstrual irregularities are common in long COVID patients and include changes to the length of cycle, duration, and intensity of menses. In a patient survey of nearly 1,800 menstruating long COVID patients, 34% reported menstrual issues, and within that, 26% had abnormally irregular cycles, and about 20% reported heavy periods. A British study of menstruating long COVID patients, Mabin et al., found that long COVID symptom severity peaked in the perimenstrual and proliferative phases of the menstrual cycle. So this is about 2 days before menstruation, and all subsequent days of menstruation, and also from the first day without bleeding to until about 15 days before the next cycle. And they found increased pro-inflammatory cytokine expression in blood serum in long COVID versus controls during the menstrual phase. So inflammation may be implicated in these symptoms. Patients felt better in mid-luteal phase, and this is really interesting because if patients feel better in the luteal phase, or the second half of the menstrual cycle, this is the phase when progesterone is higher. And progesterone exhibits immunosuppressive and anti-inflammatory effects, including helping to stabilize mast cells. And much more research is needed on this, including in the role of mast cells in menstrual cycle symptom fluctuation. Similar to long COVID, women with ME/CFS, compared to controls, disproportionately report irregular menstrual cycles, amenorrhea, dysmenorrhea, excessive menstrual bleeding, and bleeding between periods. Like long COVID, half to 2/3 of female ME/CFS patients report increased illness symptoms before menstruation. And this indicates to us that it's important as a field to consider the menstrual cycle when conducting patient symptom surveys. This is especially important when assessing baseline symptoms, and hopefully we can increasingly study longitudinally symptoms around the menstrual cycle, and I'll talk about this a little bit later. Clinical care implications. Should we be considering menstruation in terms of clinical care treatments for IACI? Should we be studying or considering hormone treatments for some IACI patients as one part of a treatment approach? Should we be considering the timing of treatments around the menstrual cycle? So these are all questions for future research. I want to emphasize that relatively few studies have investigated the impacts of long COVID on female reproductive health. I'm hopeful, though, because there's more and more research on this, both kind of emerging and currently being done. And I'll talk about some of this towards the end of the talk. That said, when we wrote this review, we found that emerging evidence suggests that similar to ME/CFS, long COVID can disrupt the menstrual cycle, gonadal function, ovarian sufficiency, menopause, and fertility. Similar to ME/CFS, premature menopause has been found to possibly be more prevalent in long COVID patients in their 40s compared to the general population. Relatively few studies have investigated long COVID in pregnant people. A paper was published, Metz et al., based on data as part of Recover, and it found that 1 in 10 women who were pregnant and contracted COVID went on to develop long COVID. It tracked over 1,500 people across the US longitudinally for at least 6 months who were pregnant and got COVID. And that's really interesting because a non-pregnant arm of Recover study found that about 23% of adults had symptoms 6 months following COVID infection. So actually the pregnant cohort had lower rates of long COVID. However, it is worth mentioning that there's a small control match prospective study in Brazil that followed pregnant women testing positive for COVID, 84 women, and 76% of them developed long COVID. And this is possibly reminiscent of research that has found pregnancy as a risk factor for ME/CFS. So I just wanted to highlight that. A large electronic health record study at Brigham and Women's Hospital in Boston found that COVID in pregnancy is associated with a 29% increased risk for children having neurodevelopmental conditions by the age of 3. And it will be important to research further whether pregnancy may be a risk factor for long COVID and how long COVID impacts pregnancy. Reproductive health conditions are also common yet understudied in ME/CFS. Patients report increased rates of polycystic ovarian syndrome, ovarian cysts, pelvic pain, gynecological surgery, and endometriosis compared to controls. A longitudinal case control study revealed early onset menopause is a risk factor for ME/CFS, and menopause exacerbated symptoms in 38% of perimenopausal and postmenopausal women for ME/CFS. So this needs far more research. A study found that women who had been pregnant in the previous year were 31 times more likely to develop ME/CFS. Pregnancy is reported as a trigger of both ME/CFS and of POTS, accounting for about 3 to 10% of cases in survey studies, and results are mixed on this, but pregnancy exacerbated symptoms in a large subset of ME/CFS and POTS patients, while other subsets report symptoms staying about the same, and some subsets even reported symptoms improving. So it will be really important to better understand why this is. Why do some patients report remission or improvement from pregnancy and others experience a progression of their illness? If we can understand the mechanisms of this, especially the immune mechanisms that I suspect are contributing to this, could the findings perhaps inform research directions for future treatment pathways? ME/CFS, POTS, long COVID, and ADS all share many reproductive health conditions, symptoms, and menstrual irregularities similar to ME/CFS. In POTS, studies have found increased rates of dysfunctional uterine bleeding, secondary amenorrhea, Besson syndrome. So in POTS, menstrual cycle hormones have been found to affect hemodynamics, and menstruation is associated with an increase in dizziness. This absolutely needs more research. In a retrospective cross-sectional observational study of 129 patients with POTS or orthostatic intolerance at Emory University, 88% of this cohort had pelvic venous compression upon undergoing either MRI, venous ultrasound, or CT scan, which suggests that this is also a very important area for future research in POTS patients, and hopefully we can expand this to other infection-associated chronic illnesses and overlapping conditions. In EDS, if you will look at the pregnancy column, it is associated with a host of pregnancy complications. So it's really important to mention the limitations of many of these studies that I just discussed. Limitations include lack of healthy control groups or comparison groups, not screening for participants for comorbid illnesses, very small cohorts, a lack of consideration in the study design of factors that may impact menstrual cycles. So again, I stress that we really need more research on reproductive health in infection-associated chronic illnesses, and we're really at the beginning of this area of our field. I think I'm going to skip this study on future research directions and this slide, sorry, on future research directions and outstanding questions in thinking about time, because I'm actually going to cover some of this in the emerging research section, and I'm happy to answer more questions in the Q&A as well. So can come back to that. So I want to discuss endometriosis further. It seems really important to mention, especially given how common endometriosis is in our patient population. I've also seen endometriosis discussed in conferences more and more as like a whole body illness that involves immune dysfunction and even nervous system symptoms. And I hear time and again, patients with symptoms exactly of IACI, sounding exactly like long COVID or ME/CFS, discussed without mentioning these conditions and the kind of comorbidities of endometriosis. So I really hope that we can see more overlaps between research on endometriosis and IACI research, and that these communities can talk even more in the future. So endometriosis affects just about 10% of women and people with uteruses. However, research suggests that between 20 and 36% of ME/CFS patients report endometriosis, and 20% of POTS patients do. So that is 2 to 3.5 times general population prevalence. And critically, the average time to diagnosis from symptom onset for endometriosis is 7 to 10 years. So these prevalence statistics really suggest the need for more research focus on this topic. In regards to long COVID, a study of non-hospitalized COVID patients found that patients with endometriosis may have increased risk for developing long COVID, but more research is needed to understand contributing factors. And people with polycystic ovarian syndrome were found to have a 28% increased risk for COVID-19 infection after adjusting for other risk factors. And interestingly, research suggests that ME/CFS and endometriosis may share some overlapping immune and endocrine dysfunction, which is listed on this slide. So I wanted to mention some interesting areas of emerging research. And one of this is whether infection and possibly immune responses to it might contribute to the development of endometriosis. In a 2023 study, they found fusobacterium in endometrial tissue of 64% of 79 women with endometriosis, and in just 7% of their healthy controls. And then mice that received a transplant of uteri tissue infected with fusobacteria grew endometrial lesions, and mice with uninfected tissue transplant did not. So antibacterial treatment then reduced both the number of fusobacterium and the weight of endometrial lesions in these mice, suggesting that this is a very promising direction for future research. There have been similar findings in epidemiology research. So this is the first nationwide population-based study to investigate whether lower genital tract infection exhibited an increased risk for endometriosis. It's a retrospective population-based study of over 79,000 patients with a history of inflammatory diseases. And what they found was that lower genital tract infection was associated with a substantially increased risk for developing endometriosis, regardless of any comorbidities that they looked at. Comorbidities that they looked at included infertility, glioma of the uterus, autoimmune diseases like lupus, MS, rheumatoid arthritis, allergic diseases like asthma and allergic rhinitis. I so wish they also looked at mast cell diseases and cancers. And they also found that those with a history of genital inflammatory diseases and with these comorbidities like autoimmune disease or allergic diseases exhibited even higher risks for endometriosis. So I'm going to talk a bit about research that I'm collaborating on that is emerging in the field, and that also, to be honest, gives me hope that we will be able to start to really explore in depth the pathogenesis of reproductive health in infection-associated chronic illnesses and hopefully treatment pathways. Okay, so in the TAL research group, we are studying mouse models of infection-associated reproductive tract pathologies. Our preprint is on the top right of the slide, and this research was led by Paige Hansen. PI is Mickey Tall, and work with incredible people on our mouse team like Sarah, Grace, Ching, Brandon, Guido, and Kunzan. All of them are on the slide. So I'm excited to share with you some of our striking findings. The mouse on the left, uninfected mouse, normal uterus, normal ovaries, normal reproductive tract. The mouse on the right was infected with Borrelia burgdorferi. This is the bacteria that causes Lyme disease. And as you can see, it developed severe reproductive tract pathologies, including enlarged, inflamed, and infected uterus and ovaries and reproductive tract. And you will notice that in our review paper that I just discussed, we did not cover chronic Lyme. And that's because despite the fact that there's some research on reproductive health in IACI, there really wasn't at the time we were writing this on chronic Lyme. And so this research served to fill a really critical knowledge gap in reproductive health in chronic Lyme. Our hypothesis was that acute Borrelia-Burgdorferi infection may increase risk for gynecological disease in mice, and we used a marine model, female B6 mice, infected with Borrelia-Burgdorferi intradermally, and then collected female reproductive tract tissue. And then our mouse researchers analyzed and imaged it. And after just 9 weeks, of infection, Borrelia-Burgdorferi was detectable in female reproductive tracts in these mice. And we found using really deep label-free imaging done by the U Lab and Kunzan Liu that Borrelia-Burgdorferi are more likely to be in endometrial layers of the uterus versus myometrial layers. We also saw immune cell infiltration in response to infection. With long-term infection, we saw differences in growth pathology in these tissues, increased rates of glandular cysts, endometrial hyperplasia, which is a thickening of the lining of the uterus. And we see differences in the external genitalia of these mice, increases in swelling, discharge, differences in the vagina as well, thickening of the lining of vagina, and also increase in immune cell infiltration, which is very interesting, and sloughing off into the lumen of the mouse vagina as well. The fact that these mice were infected for such a long period of time, it made us think about whether it was the length of infection or was it that these mice were older and that age was actually a factor in this pathology. So our incredible mouse team took 15-week-old mice and 1-year-old mice and infected them both with the same length of time. These 1-year-old mice are equivalent to about middle-aged people. So future research implications could be that we need to take age into account when thinking about reproductive health in infection-associated chronic illnesses, because the infected aged mice had far worse pathology. So this raises questions about differences in immune responses to infection in younger versus older mice and resulting in gyne pathologies, and highlights the importance of this area to just research this further in humans as well. We also asked, does our mouse data correlate with human data? And so we worked with Dr. Hannah Leela and Dr. Nessa Armstrong's labs. They conducted human epidemiological research using 3 different databases. And this was some of the first epidemiological research on reproductive health impacts of chronic Lyme disease. And what was consistent across all 3 databases was that a previous history of Lyme disease significantly increases risk for a variety of gynecological diseases. Findings include increased rates of endometriosis, polyps, heavy menstrual bleeding, painful periods, fibroids. This at this point should sound really familiar because it echoes what we found in our review of reproductive health impacts of other infection-associated chronic illnesses, and really fills in that gap to show that chronic Lyme has similar findings in this illness as well. So in summary, both in humans and mice, Lyme disease statistically significantly increases risk for a variety of gynecological diseases, and that Lyme disease may have an additional manifestation as a gynecological disease, which, given the statistics that I provided in this talk, I would hypothesize this may be the case for several infection-associated chronic illnesses. Additionally, I collaborated with the Mayo Clinic and Dr. Stephanie Graich on a study of their long COVID clinics, and we found that 61% of long COVID patients reported that they had a genitourinary condition newly develop or become worse following COVID, which again echoes the research that I've discussed in this talk. Other emerging research I want to highlight is a study happening right now that I'm very excited about, that I'm a collaborator on, and it gives me a lot of hope. Natalie Thomas recently presented and gave an echo talk, and led by Natalie, this study tracks hormone fluctuations in immune markers and metabolic markers and symptomatology around 2 menstrual cycles in long COVID and ME/CFS in healthy controls. And the study is collecting urine and blood in participants, daily symptom tracking, and really seeks to map the complex interactions between endocrine, metabolic, autonomic, and immune systems across the menstrual cycle. And this is so important because we've really come full circle from the beginning of the talk, because in my first slide, I discussed how common symptom exacerbation is in long COVID and ME/CFS around the menstrual cycle. And with this research, with our study, hopefully we'll be able to understand why this is happening, and incredibly important if this is treatable. Finally, at MIT, the Tull Research Lab that Iman has been running the largest clinical study in MIT history with cohorts of acute and chronic Lyme disease, long COVID, and long COVID. PI is Mickey Tall. Our lead study nurse is Yuri Kim. I was incredibly involved in the development and design of this study. It involves multiple different types of cutting edge, non-invasive, neurocognitive, neurological, autonomic testing, blood flow, connective tissue assessments. And we collect biological samples like blood, urine, saliva, throat swab, also vaginal and rectal swabs, which are optional. And we're interested in pathogen detection and microbiome and immune profiling in these samples. So we hope to have a lot of reproductive health data to come. I was going to talk about clinically relevant emerging areas of research, but I think I am going to skip that because I want to leave enough time for Mita's incredible talk. But what I did here is I highlighted areas of emerging research in endometriosis that I think may be particularly relevant to both, potentially an audience of physicians and also potentially for IACI research in the future. And I'm happy to answer questions about this in the Q&A. And just for clinical takeaways, reproductive health conditions and gynecopathologies are relatively common comorbidities in female patients with IACIs. Symptom exacerbation around the menstrual cycle is very common in IACIs. Research suggests that patients may feel better in the luteal phase. It is so critical that we study the intersection of hormone fluctuations and immune and metabolic dysfunction and symptomatology in long COVID and IACI. Reproductive health conditions like endometriosis typically have lengthy diagnostic delays, and research is ongoing, but similar to IACI, it may involve immune, hormonal, metabolic dysregulation. Mouse models show that certain pathogens can induce endometrial lesions and gynecopathologies in mice, and future treatment directions could include GLP-1s, targeting creatine, mast cells, and prolactin, and even antimicrobials. Happy to talk about that in Q&A. I had to skip that part of the talk. Reproductive symptoms can overlap with IACI, GI symptoms, spinal symptoms, pain symptoms, menstrual-related symptom fluctuations in IACI can also mimic some of these symptoms. So it's really critical to comprehensively screen for comorbidities and when appropriately consider potentially referring for further testing and imaging, like for pelvic congestion syndrome, and referring to endometriosis specialists. So I now have the pleasure of introducing Mita. And I'm coming back to our Maestro slide to kind of set up her talk. And the study consists of cohorts of 60 participants with long COVID, chronic Lyme or acute Lyme, and healthy controls. And when we were designing Maestro years ago, I proposed and advocated to include a number of things in the study. And some of these included things like autonomic testing. We do a NASA lead test. I really wish we did a 10-minute active stand test. We track external carotid artery flow with Lumia earpiece, especially during autonomic testing. I really advocated for connective tissue assessments, various surveys, and studying differences in patients who commonly report nail issues, such as loss of lunula. And that evolved into our Nailfold Capillaroscopy research. And Mita has assisted in study visits and has been doing just terrific analysis of our study data, and is going to talk today about findings from Nailfold Capillaroscopy within the context of some of the elements I just mentioned. Mita, take it away, and I'm happy to kind of provide more thoughts on future research directions and why this is so important and potentially exciting for these illnesses, but I can do that afterwards. So many people to thank. Research is a team sport, and it is not possible without the collaboration of many researchers. So I want to thank the Patient-Led Research Collaborative and my co-authors with whom I wrote the review. They're at the top. The Tall Research Group, PI Mickey Tall, the Sanat Armstrong Lab, the U Lab, the Olilla Lab, Dr. Stephanie Grach at the Mayo Clinic, the Celine Lab with Lisa Celine and Anna Gill, the Armstrong Lab with Chris Armstrong and Natalie Thomas. I want to thank my mentors in the field, Ron Davis. I want to thank Cindy Bateman. It is such a treat to be here today because BHC does such incredible and important work and are leaders in medical education and in training physicians and in clinical care and in research. And I want to thank Talia Rusioni, the executive director of BHC, and Clayton Powers, who helped organize this today and invited us to speak. And thank you everyone for coming. I appreciate it and look forward to hopefully future presentations in the future. Thank you so much.
Alrighty. Thank you everyone for your time today. Thank you, Beth, for inviting me here today. And thank you to the University of Utah and the Bateman Horne Center for this opportunity. And so I have no financial relationships to disclose. And the root of our investigation here today, I'm going to be talking about Nailfold capillaroscopy and some of our insights from the MIT Maestro study. And the root of this investigation was centered around a key topic, which is that many long COVID and ME/CFS patients report orthostatic symptoms, but often don't meet criteria for orthostatic hypotension or POTS. These symptoms range from dizziness and lightheadedness to pain and nausea, and are commonly reported by our long COVID participants in the Maestro study as well. And one retrospective paper, as shown on the left here, found that the most common clinical symptom after COVID-19 was actually these orthostatic symptoms without tachycardia, present in 41% of their cohort, size of 27. The study on the right by Van Kempen et al. Found that 82% of ME/CFS patients in their cohort were misclassified as having normal hemodynamics using the head-up tilt test alone. And it wasn't until the researchers analyzed the Doppler echography that they found altered hemodynamics. This brought us to our research question, which is, are there any other exploratory tools, such as Nailfold capillaroscopy or the Lumia earpiece, which I will introduce shortly, that could help us better understand blood flow dynamics and dysautonomia? As part of the Maestro study, as Beth mentioned, at the end of the study visit, we conduct the NASA lean test, measuring heart rate, blood pressure, pedal pulse, oxygen saturation, and symptoms at every minute during the 10-minute leaning stand. And we compare this to the supine resting heart rate and blood pressure. Our results showed that participants Sorry about that. Our results showed that participants with infection-associated chronic illnesses most had experienced several orthostatic symptoms, and most commonly, these symptoms included lightheadedness, fatigue, weakness, shaking, their hands and feet feeling very cold, and feeling sweaty. In addition, most participants with infection-associated chronic illnesses demonstrated blood pooling in their hands and feet being very cool to touch, and pallor as well. However, when we analyzed the heart rate data, we found that very few participants met the criteria, participants above this horizontal dotted line, for POTS. Specifically, 71% of our participants that had orthostatic symptoms did not meet the criteria for POTS, which aligns with the findings from the previously shown studies as well. And this brings me to the guiding research questions for today. 1, how can we non-invasively assess microvascular health and blood flow? 2, what data can we extract from these capillaroscopy images? 3, are there differences between our cohorts, specifically looking at our controls, long COVID, and chronic Lyme cohorts in the Maestro study? 4, are there changes when we add in orthostatic testing from the NASA lean test as a perturbation? And 5, how does blood flow to the brain from the Lumia earpiece change with the NASA lean test? So key question 1 to start off with, how can we non-invasively assess microvascular health and blood flow? And we can do this using Nailfold capillaroscopy, which is a non-invasive imaging technique used to visualize capillaries at the base of the fingernails. For example, from this region of the cuticle, we can visualize a high-resolution image such as this using just a simple light microscope, such as the SMART-G scope. This is the one used in the Maestro study, but there are several commercially available with even higher resolution and different capabilities as well. And these capillaries are the smallest blood vessels. They are the site of oxygenation and nutrient delivery to the body's cells, as well as waste removal. And previous studies have also established that some perturbations, such as temperature and smoking, can alter the size and shape of these capillaries within minutes. And we wanted to ask how postural changes could potentially do the same. Currently, Nailfold capillaroscopy is primarily used in rheumatology to screen for and to monitor scleroderma, Raynaud's disease, lupus, and rheumatoid arthritis. Some other diseases with unique capillary signatures include type 2 diabetes and dermatomyositis. These are some examples of what prominent abnormalities in the capillaries are present across the conditions shown. And in terms of our methods, we followed the gold standard for image collection, which is we used 250x magnification. We collected images from 2 adjacent fields in the middle of the finger with a 1 linear millimeter field view per image. For example, if this was the finger we were collecting the data from, we took image A and image B. And this was performed for the 4 fingers on the hands, except for the thumbs, and also on the big toes. This was done twice during the study visit, once before and once after the NASA lean test, resulting in 40 total images per participant. This typically took less than 10 minutes per collection to highlight how quick Nailfold capillaroscopy can be as a tool. And this brings us to key question 2, which is what data can we actually extract from these images that we've collected? First, I want to start by showing you an example of healthy capillaries from one of our control participants. And the key features here to note from what we understand about capillaries in the literature is that these are very linear. They're about 1 blood cell thick. They form these long loops, which increases the surface area for gas exchange, nutrient exchange. They're homogeneous in structure and shape. They have a high density, specifically above 7 capillaries in this 1 millimeter field view. We don't see any background redness, which is to say that the redness you see in the image is largely confined to the structure of the capillary. They're very parallel to each other, almost like a picket fence. It's been described to us. There's no branching that we see here. There's no leaking or pooling of blood, and there's also no hemorrhaging of blood that we can see here. And these are the key features that we wanted to keep in mind throughout our analysis. However, for our participants with infection-associated chronic illnesses, the capillaries often look strikingly different. Each image I'm about to show is from either a long COVID or a chronic Lyme participant. We often see these enlarged or dilated capillaries that can even progress into these giant capillaries, for example. We see this severe background redness as well, where the redness you see in the image is not just contained to the capillaries, but you see this in the background as well. This ballooning or pooling of blood that we've observed, microhemorrhaging, tortuosity, which refers to this curvature-like phenotype, meandering, where the vessels actually cross over upon one another, non-parallel, where they veer sideways instead of being parallel to one another, branching, where they form offshoots off of each other, short length, and low density. And we separated these into 4 categories based on our understanding of what they might represent and our potential hypotheses here. So we have a swelling and an inflammation category. We have a leaking category. We have an irregular shape and linearity category. And lastly, we have this low perfusion category. So this brings us to our third key question, which is what are the key differences that we can observe using capillaroscopy between our cohorts? First, I'm showing here 7 control cases from the Maestro study, all of whom reported full recovery back to their baseline from acute COVID-19. And as you can see, they meet the criteria that we discussed before for the key healthy features. However, this is not the case for the 8 cases I'm about to show here of participants with infection-associated chronic illnesses. We have 3 participants here, cases from chronic Lyme, and we have 5 long COVID participant cases as well. As you can see, these are strikingly different to the healthy examples we showed on the previous slide. And I've highlighted here some of the most prominent and key features we can observe from these images. For example, in this top left here, we see enlarged, branched, non-parallel capillaries. Here we see a high degree of microhemorrhaging and enlarged capillaries, short length, background redness and enlarged capillaries, hypoperfusion and low density. Here we see a lot of tortuosity and non-parallel capillaries, background redness and enlarged capillaries, and lastly, enlarged and tortuous capillaries. I've also highlighted here the duration of illness reported by each participant, as this is one of our hypotheses for key factors that might be impacting the microvascular alterations observed. And upon segmentation of these images to quantitatively compare the 7 control cases with the 8 cases with infection-associated chronic illnesses, we found 2 key features were significantly different between the cohorts. And this segmentation was performed using 2 methods, automated tools and manual tools. And the automated tools to really highlight that this could be done quickly, this can be done objectively as well, using a validated software. And in our results, we found that specifically, the enlargement percentage and the tortuosity percentage were significantly different in our cohorts, with infection-associated chronic illness participants being more likely to have a higher percentage of both. This brings us to our next question, which is, are there changes when we add in orthostatic testing, specifically the NASA lean test, as a perturbation? And here are the same 7 control cases I showed previously. We can see on the left are their pre-NASA lean test images, and on the right are their post-NASA lean test images. And we see not much changes observed in their capillaroscopy from before to after the NASA lean test. These images were collected from the same finger. As you can see, we tried to maximize it being the same location as well. You might be able to pick out certain capillaries that we've overlapped here as well. And this is not the case for our infection-associated chronic illness participants. We see very strikingly dynamic changes with the NASA lean test, with features that were not present or not as severe before the NASA lean test. You can see this clearly in all of our cases here. And we even saw some participants with ballooning or pooling of blood that occurred after the NASA lean test, after the 10-minute standing lean. And I've highlighted here the symptoms that each participant noted most often during the NASA lean test as well to show that these changes are co-occurring with certain symptoms. Our next step is to understand what specific changes we can see in the capillaroscopy that are correlating with specific symptoms as well. And this brings us to our fifth key question, which is how does blood flow to the brain from the Lumia earpiece data really correlate with this capillaroscopy and the entire bigger picture of blood flow and dysautonomia? And so the second exploratory tool we use to better understand blood flow and dysautonomia is the Lumia earpiece. And in this study by Van Kempen et al., 90% of people with chronic symptoms upon standing were found to have a low blood flow to the head. The Lumia earpiece measures blood flow to the head using the shallow ear artery, which is a proxy for external carotid flow. Lumia has shown data from this device in a test kind of similar to the NASA lean test in terms of it being a postural change, where participants went from standing to having their leg raised, and they observed this increase in blood flow to the head. And so we equipped our participants with this earpiece for the NASA lean test during the study visit, measuring carotid flow throughout. And as you can see in this example, this vertical line here is when participants stood up, and the time before is while they were lying down, the time after is while they were still standing up. And we can observe this continuous measurement of carotid flow over time. Here you're seeing the same pre and post NASA lean test images from the 7 control cases, and overlaid here is their Lumia earpiece data. And so for the participants for which we had this quality data, you can see that there was not much change in their Lumia earpiece data, little to no change in carotid flow during this test upon standing even. And this was very different, as you might be expecting, in our infection-associated chronic illness participant cases. As you can see, for nearly all participants shown, there was a drop in carotid flow here upon standing that did not recover through the NASA lean test. Some Lumia data showed a reduction in carotid flow of up to 30% during the standing portion of the NASA lean test. And so this is one of our ideas and potential hypotheses as to why participants might be feeling certain orthostatic symptoms, such as dizziness and weakness upon standing, despite not meeting criteria for POTS. And so despite these orthostatic symptoms, these capillaroscopy changes, and Lumia data shown here, only one participant out of these 8 you see here actually met criteria for POTS. And so we're very interested in further assessing these correlations between the Lumia data and the capillaroscopy, and to further investigate and validate their use as tools alongside orthostatic testing. Our main conclusion here is really to say that it's not that our participant symptoms are really coming from nowhere, but rather that there are these tools like capillaroscopy and like Lumia that can potentially help us understand these symptoms better. And eventually, one of our goals is even to train a model with enough high-quality images, as has been done before for scleroderma, to provide this type of probability score, or maybe even a severity score specific to the capillaries, to help guide clinicians or researchers in decision-making. I also want to show you this video of the capillaries where you can actually see the cells moving. So I want to highlight here, you can see these cells moving, the white blood cells as well, through the capillaries. And I'm highlighting this because there is such an immense volume of information contained in this tool. And for the future, we only collected images in the Maestro study, but for the future, one of our goals is to collect these videos as well, which contain even more information. And in summary, I just like to say that one, Nailfold capillaroscopy, as you've seen, is this quick, non-invasive, it's inexpensive and easy to use tool that can reveal dynamic changes with the NASA lean test. These changes correlate with patient-reported orthostatic symptoms, even in the absence of tachycardia or hypotension, as we've observed in our clinical study. Nailfold capillaroscopy and Lumia earpiece data may also serve as additional exploratory tools to better understand blood flow dynamics during the NASA lean test and potentially in other applications as well. And further analysis and research is definitely required to determine which key features specifically could assist best with longitudinal monitoring, severity measurements, or even screening. But we're very excited about the future for this tool. And I'd like to really thank the team. Thank you to Dr. Tall. Thank you to Beth and the University of Utah, Bateman Horne Center, all of our collaborators and funders as well, and of course, our participants. Thank you.
Thank you. That was excellent and so interesting, and it gives us so many ideas of other ways that we can analyze and help diagnose patients and support them, showing that it's a real biological condition. So I'd like to first mention or shout out our mentors who are on this call, Dr. Cindy Bateman, Jennifer Bell, and Melanie Hoppers from Bateman Horne Center, and give them the opportunity to ask any questions. But this has been excellent, and we have some questions in the chat as well. One question I have is, so can clinicians easily use this in the clinic to help identify some of these changes? That's kind of what you mentioned. Yes. And so the other question, Beth, you mentioned that you wish you had done the active stand as well, or instead. Can you comment on that?
Well, that is very much the tool that, or the testing that the field has moved forward with in terms of integrating into studies, and it's kind of an official way to study dysautonomia. And so, yeah, if there are many different things that I think if we were designing Maestro now, we would tweak. And that's just one of them to align with other studies in the field. But just going back to the capillaroscopy research, I think every day about the patients who fall through the cracks. We don't have enough autonomic neurologists for the size of the patient population. We don't have enough tilt table testing. If someone can access a tilt table, hopefully it has transcranial Doppler ultrasound. And hopefully it doesn't take the year plus that it often takes to schedule these appointments. And then what happens in between, right? And so many patients are falling through the cracks of dysautonomia diagnosis, not meeting BP and HR, requirements for diagnosis, without, measurements showing that, in fact, they both have dysautonomia symptoms, orthostatic symptoms, coupled with cerebral blood flow, like Peter Rose research shows. And this is across, we're seeing this across infection-associated chronic illness as a shared feature. And so I'm really excited because capillaroscopy, it's affordable. It's accessible. There are instruments that range from $35 to $3,000. And I think we need tools to help track blood flow changes within clinical trials for treatment, for endpoints and treatment assessments that are accessible. We need more at-home clinical trials, and could this be an at-home tool? We need also, the ability for physicians to be able to track disease progression and measures of that, or improvements with treatments. And so this is such nascent research. This is just emerging nascent research, but I'm excited about this within that framework, that it kind of addresses a much needed gap in both our clinical tools and then our research tools. And I'm hoping future research directions include, seeing whether results from capillaroscopy research align with some of our findings from other blood flow research. Blood clots, endothelial dysfunction, Dr. Sidstrom's microvascular shunting as part of his PEM model. What do any findings correlate with that? And could this be kind of some future research directions? And also, why do so many patients report differences in their nails? And does that perhaps represent something a little bit deeper that we need to explore, such as disappearing lunula? Is that associated with any of these findings or circulatory issues? Anyway, I could go on and on, but I'm really excited about this research and then really future research applications, both within research and potentially someday, potentially clinically.
No, I agree. This is super exciting. And also, I love how you combined looking at cerebral perfusion with
With
the
Illumia.
perfusion, yeah, with the Lumia and then also
Yeah.
the capillaroscopy and combining that with nasoline testing. So it's amazing.
Yeah, and asking about symptoms too. The data, we'll be going through this data for a while.
One of the questions was, how do you standardize the area captured through capillaroscopy before and during? How did you standardize that?
An excellent question. In our clinical study, for the sake of more so time, as you saw, we collect a wide variety of information, and mostly for operator ease, we approximated the region to standardize area. So in some, you'll see we have a almost identically overlapping region. In some, we tried our best. And so definitely for future studies, it's something we have in mind to standardize further. Maybe we could outline the measured area with a pencil or something, but that's definitely a consideration.
And also, if people are wearing nail polish, it makes it hard to especially study them and characterize their nails.
One question we also had from your section, Beth, was any data from patients with hormone IUDs? Oh, you're on mute. Sorry. I don't know how that.
That's such an interesting question. So not within IACIs. And we've applied for research to do low dose treatment research with hormonal treatments. Did not get it, but I'm hoping that there will be more analysis of current data as well as clinical studies on hormone treatment and studying impacts, especially longitudinally across the menstrual cycle, on not just reproductive symptoms, but chronic illness symptoms. There's often a misunderstanding. People think that people are experiencing just a fluctuation of menstrual symptoms, and it's not. It's a fluctuation of many different chronic illness symptoms that maybe people don't often associate with the menstrual cycle.
That's so helpful. Dr. Brown?
This is such a fascinating talk on both of them on so many levels. Very interesting. From my background is actually in Lyme disease research, and looking at different mouse strains and persistence of bacteria versus baseline cytokines. Have you ever looked at that from sort of your models with sort of the difference between persistence bacteria, because they do travel within the connective tissue and persist within the connective tissue, versus just altering of the immune system and things like IL-10, which have been shown in different mouse strains? Just curious about that.
Yeah, so that's a different talk, but great question. And yeah, so actually the very first thing I ever pitched many years ago when I joined the lab is that we absolutely had to study connective tissue damage and potentially connective tissue disorders following infection, and in our mouse models. And I have a talk on that, and we will have a preprint on that. So yes, we did find systemic hypermobility stemmed from infection, and especially in tails. And we were able to really mimic the EDS mouse model where you tie their tails in knots, which is not possible in a healthy mouse, but without, a genetically modified hypermobile EDS mouse, but with just infection. So that is a separate talk. And I'm happy to go more into that. And also more information will be available hopefully this year on that. But yeah, if
That's so cool. It
I don't mean
makes
to I don't mean to promote another talk, but if
No,
you look
no,
if you
yes,
look
we
at
would
my
love to have you back.
my Mass ME talk, you'll find I presented it there. Okay.
I think that's so good that, like, so many of these things overlap, and that, it validates all my hours of measuring mouse ankles as an undergraduate. So it's great to see your trainee there, who will then go on to medical school as well, because I think we do need people that are really looking at these complex disorders that have multiple phenotypes and also predominantly affect women. But yeah, you're doing amazing work. Thank you.
Can I just give some flowers to Mita? She has just been so incredible to work with and so embracing of this research and bringing such incredible talent to this research. We're so sad to see her go. And some of the research we're going to be publishing that Mita and I collaborated on is on environmental sensitivities within infection-associated chronic illness. And I'm so excited to share those findings. So hopefully, Mita, we can come back and give more talks.
Absolutely.
Thank you
Just
very
reach out
much.
to me. I would love to have you back and share updated research. We're always looking to be on the cutting edge with being able to disseminate the research is a huge part as well. Because you can do it, but we need to disseminate it to the doctors in the field treating and the patients so that they feel validated that this is real. This isn't psychological. There are things you can find that show what's going on with the body. Well, thank you so much, Beth and Mita, and everyone who joined today. Don't forget to claim CME credit for attending. Our next session will be on sex, intimacy, and pelvic health with Dr. Katie Wolf from University of Utah. So we'll look forward to seeing you all next time.
Thank you so much.
Yes, thank you.